Whatever may be the source for your dermatology bacterial infections topic, this video is going to help you to very quickly revise the entire bacterial infections topic in a very short duration. Watch this video till the end to know all the important points very quickly and crisply. Hello dear students, myself Dr. Maddineni Srinivas. Let us begin the discussion without any further delay. So first we are going to cover the follicular pyodermas. Pyodermas are the infections of the skin having pus. Follicular pyodermas, those infections which are going to involve the hair follicles commonly because of the Staphylococcus aureus. And what are the three types? Folliculitis, Furuncle and Carbuncle. Folliculitis is going to involve the hair follicle where there is going to be a pustule. Most common hair follicle lesion. Treatment topical antibacterials will be sufficient because it's going to be very localized infection. Coming to the furuncle, also called as a boil, here there is going to be perifollicular area involvement and we are going to have the tender nodule associated with pus. Here there is going to be a very important involvement of hair bearing areas which are subject to friction. Warm compresses, incision and drainage is going to help if at all this condition is severe. Next is carbuncle, coalescence of multiple contagious hair follicles which are infected. We can say this is a group of furuncles which are present in these patients who are uncontrolled diabetics, and also they are going to have the involvement commonly over the nape of the neck, presenting as multiple sieve-like discharging pus points. IND needs to be done if there is a lot of pus, and systemic antibiotics we should admit the patient. So this is about the folliculitis, furuncle, carbuncle. Next is Sycosis Barbae. This is a recurrent chronic pustular staph infection specifically affecting the beard region, Barbae beard region. It involves the whole depth of the follicle, but it is typically a non-scarring infection, so the hairs are going to be retained. So remember this point. Next we have this non-follicular pyodermas which are localized varieties. So what are the important diseases? Impetigo, eczema. So these are the ones which could be due to staph or streptococcus. So let us quickly see the points related to impetigo and eczema. Impetigo again, non-bullous impetigo and bullous impetigo. Non-bullous is also called as impetigo contagiosa, which could be due to staph or strep, and it is going to be limited to the epidermis. It is superficial infection where there is going to be honey colored crust. This is very important buzzword to remember. Most commonly occurring on the face of the children, and very important complication because the causative organism could be streptococcus. It is PSGN, post streptococcal glomerulonephritis. Coming to the bullous impetigo, remember it is always Staphylococcus aureus, the 70 and 71 phage types, producing the exfoliative toxin A and B, which targets the desmoglein 1, which is present in the upper epidermis, producing the subcorneal split. That's the reason why there is going to be a flaccid bullous lesion which may rupture, and it's going to produce this varnish colored crust, which is very important point. And there's going to be hypopia on sign. The air pus level will be there, and it may disseminate to produce the staphylococcal scarlet skin syndrome in the infants. Right now, coming to the eczema, it is mostly due to the streptococcus, and you can remember it's a deeper variant of impetigo where the involvement is going to be present in the upper dermis, not only the epidermis. And you can see the patients having punctured ulcers, and also adherent crust will be there. It's a deep infection. The scar can form because of the dermis involvement, and also it is going to have potential systemic spread also. Coming to the non-follicular pyodermas or spreading variety, here the patients are going to have rapidly expanding erythema and edema, but they differ primarily by the depth of the tissue invasion. As you can see here, we have these two types, erysipelas and cellulitis. Erysipelas is also called as Saint Anthony's fire. Remember, it's going to involve the upper half of the dermis and also superficial lymphatics, and it is always caused by group A beta hemolytic streptococcus. And also you can see very sharply demarcated raised borders as if you are seeing a wall separating the involved skin from the normal skin. And also you can see the involvement of the ear, which is called as million ear sign, and in the ear there is no subcutaneous. That is the reason why cellulitis cannot occur and affect the pinna. So that is a very important differentiating point. Cellulitis can progress to abscess formation or necrotizing fasciitis, but it cannot involve the pinna because pinna does not have the subcutaneous tissues. Coming to cellulitis, it is a deeper infection. Lower half of the dermis subcutaneous tissues are going to be affected. It could be strep or staph. There is no specific thing here. The margins are going to be very ill-defined, diffuse, and also blending. We cannot differentiate between. It is very difficult to differentiate between the normal skin and the infected skin. There are ill-defined margins. Coming to the toxin-mediated infections, here the certain strains of the bacteria produce certain systemic toxins that cause widespread cutaneous manifestation without any bacterial invasion of the skin. This is very interesting. So the first one we have to remember is staphylococcal scarlet skin syndrome, which is also called as Ritter's disease, which is just an extension of the concept of the bullous impetigo, in which the epidermolytic toxin or exfoliative toxin A and B from the distant Staphylococcus aureus focus, which could be otitis media, conjunctivitis, and also bullous impetigo. They are going to cleave the desmoglein 1, which are present in the stratum granulosum, producing a subcorneal split, and it's going to produce sheet-like epidermal peeling. Very important term to remember. Another disease also can produce this sheet-like epidermal peeling. What is that? Yes, it is toxic epidermal necrolysis. And coming back to the Ritter's disease, staphylococcal scarlet skin syndrome, it is a true positive Nichols in which we are going to see in this condition, because the underlying problem here is acantholysis. Remember this very important point recently asked in the examination. So how to differentiate between SSSS and TN? Very easy. TN is usually seen in the adults, whereas SSS is seen in the infants and young children. That is the first important point to differentiate. And of course it is drug induced TN, toxic epidermal necrolysis. It's going to be deep. It's going to cause the necrosis of the skin at the dermoepidermal junction. Here it is going to be superficial subcorneal split, and mucosa is going to be spared in SSSs, whereas it's going to be very prominently involved with hemorrhagic crusting in TEN patients. So these are some of the differences which are very, very important. Next, toxic shock syndrome. The toxins here are Staphylococcus aureus toxins, which are going to be seen very precisely. Buzzword is tampon using menstruating females. Very important point. Patients are going to present with acute fever, macular erythema, and palmoplantar scaling is going to be there. Next is scarlet fever associated by group A streptococcus GABHS, presenting with generalized erythematous rash 24 to 48 hours after streptococcal pharyngitis. Right. Next, we are going to see the cutaneous corynebacterial infections. These are the commonly affecting intertriginous, that is the fold areas and also the appendages. So what are those three conditions which are important? First one is the erythrasma, which is due to Corynebacterium minutissimum, presenting as in the axilla, groin and the toe web spaces as asymptomatic, well demarcated, hyperpigmented or erythematous macules. On wood slump examination, coral red fluorescence can be seen due to the coproporphyrin 3. Coming to the trichomycosis axillaris, the organism is Corynebacterium tenuis, presenting as asymptomatic yellow concretions or deposits present over the axillary hair. And it's a misnomer, it is a bacterial infection, so very important to remember. Pitted keratolysis due to Chytococcus sedentarius or Micrococcus sedentarius, presenting as punched out pits or depressions on the weight bearing soles and also the palms, it's possible, and associated increased sweating can also be there. This enzyme keratinase is going to digest the stratum corneum, producing the pits. Next is pseudomonas infections. So here remember they are going to be moist environments and also immunosuppressed hosts, which are going to be very important clues in the question. So ecthyma gangrenosum, severe manifestation of the septicemia of the pseudomonas occurring in the immunocompromised patients. It presents as hemorrhagic bullae that ultimately evolve into necrotic ulcer with a black eschar. This term is very important, eschar. It is also seen in some other conditions which you are going to see. All the differentials of eschar are very important, right? And it is eschar is forming because of the infarction of the skin. Next is hot tub folliculitis. Here there is going to be pruritic tender pustules around the hair follicles, predominantly over the trunk, after taking bath in very ill maintained spas. Next is greenish discoloration of the nail because of the pyocyanin pigment produced by the pseudomonas, is called as green nail syndrome. So next, cutaneous anthrax. These are also very important. So remember, Bacillus anthracis is the causative organism, and there is going to be association of the persons who are having contact with the cattle. It starts as a painless papule that ultimately evolves into characteristic malignant pustule. Remember, this is a misnomer because this is neither malignant nor this is a pustule. So this is not true pustule but an ulcer which is having a central black eschar, again black eschar, surrounded by a rim of vesicles. Very characteristic description. You have to remember this description. Next, meningococcemia produced by Neisseria meningitis presents with fever, neck rigidity, rapidly spreading petechial or purpuric skin lesions. Very interestingly, the term which is used is the angular infarcts which are seen over the skin. Next, cutaneous eschar. What are the important differentials? So we have already seen the cutaneous anthrax. Okay, so here painless ulcer, central black eschar, rim of vesicles. If you remember, it is malignant pustule, and also animal cattle exposure is going to be there. Animal or cattle hides. Scrub typhus, again another very important disease where eschar is going to be there. The patients are going to have fever, CNS symptoms transmitted by chigger mites, and there is going to be the doxycycline, which is a drug of choice. Brown recluse spider bite can also produce eschar and ecthyma gangrenosum. Immunocompromised patients, pseudomonas septicemia. We have already discussed this. So what are the topical antibacterial which can be used in these patients? Yes, for localized and superficial bacterial infections, there's going to be topical therapy which is preferred over the systemic antibacterial therapy. So we have the mupirocin, fusidic acid, retapomylene and ozenoxacin which can be used topical, which are very easily available in the India. So I hope this video was helpful. If so, please do that like button. Also do subscribe to this channel for more such videos on a regular basis for awesome dermatology videos. And if you have any doubts, you can put the doubts in the comment section. Thank you so much, dear students. Happy learning. Bye bye.